For the next talk, I'm going to cover two diseases, cervix and endometrial cancer. There's a fair amount of material for us to get through. So I try to limit the presentation to a few areas, but again, I really encourage you to write down your questions or send them in through the iPad so we can get to them. These are my disclosures. As you may recognize, Brad and I both do a lot of drug development, so we have a lot of relationships with companies as we try to continue to develop new therapeutic strategies for these patients with ovarian, cervix, and endometrial cancer. So as I mentioned, I'm going to focus on advanced disease and recurrent disease, talk a little about the prognostic factors and then the emerging roles of novel therapeutics. And I'll start with cervix cancer, and although this has been an exciting area for us this year, over the last year, I should say, because of the approval of a new agent in this space, this is actually a slide I think I stole from Brad. So, but you can see what the issues are here. So we have a significant global burden in countries that have no opportunity of actually having to participate in the kinds of stuff we're going to be talking about today. So this is our problem. And it's even amplified by the fact that this is a completely preventable disease. So if you want to talk about how we're going to make advances in cervix cancer in the future, it's going to be all about vaccination. And in countries where there's not the hope for that, it's actually something as simple as pap smears. So I was just in Pakistan about 3 weeks ago and learned that there is an ongoing effort to introduce pap smear screening to the country. Pap smear screening, something we've been doing here for 70 years. So a lot of what I'm going to be talking about really is really relevant here, but globally, our issues are in a much different space. So cervix cancer, as you well know, is a highly survivable disease when it's found early. When we see these patients because of vaginal bleeding, generally it's reflective of early stage disease, and we can do something about it. Both surgery and radiation are curative in a large number of patients, and you can see that based on the different prognostic factors by stage. Unfortunately, about 40% of the patients who present to us already have advanced disease, which generally is locally advanced, so it goes into this parametrial tissues out to the pelvic sidewalls, and then in a few unfortunate cases we'll see with metastatic disease outside of the pelvis. The recurrence rates are linked to stage. While in the surveillance for these diseases, like most of our solid tumors, are actually heightened in the first 3 years because that's when the majority of the recurrences happen. And with cervix cancer, it follows the rules of thirds. So there's a third that are isolated in the pelvis area, there's a third that are in metastatic, and there's a third that actually have a distant and regional recurrence. When patients recur, we have a number of different options at our disposal. And you can see by the graph over on the right that these various different options have different impacts. But you have to know that the surgical option, which looks to be the best, is really only focused on a very small proportion of patients. These are women who have recurrent disease in an irradiated field in an area that can be removed by removing all of the pelvic viscera. We call that a pelvic exoneration. And you can tell by the choppiness of the curve here that there are very few patients that actually fall into this category. However, we have about a 40, maybe even 50% salvage rate for patients that are amenable to exoneration. One of the trends regarding this disease is that there are fewer and fewer candidates. And I have sat on the division for the American Board of Obstetrics and Gynecology, which monitors surgical experience across the gynecologic oncology programs. And I can tell you this is one of the dying procedures that we're seeing. And that's because our ability to control local disease has actually gotten so good. So there are fewer and fewer candidates for this surgery, for that particular option. For radiation, the few patients that have not received radiation or have isolated recurrences outside of an operative field, sometimes we can salvage, and that's why that's on that green line. For the majority of our patients, it's all about chemotherapy, and I thought it was important to see this line about palliative care because it is extremely difficult for us to do best supportive care versus treatment. I know you guys do it all the time in multiple other solid tumors, but I can tell you that in this patient population it's extremely difficult. We've tried many times. It's very hard to do. But you can see that our track record with chemotherapy has not been all that great. And what I'm going to show you today is that we are moving that curve away from best supportive care with some of the newer modalities. Now, the GOG has spent a very focused effort on trying to define the standard. My colleague Brad actually is the chair of the cervix committee at the NRG and has been responsible for a lot of this development. So a lot of credit goes to him and his committee and his investigators. But essentially, we have started with the platinum when it became available, and we worked our way through multiple randomized trials trying to define the best outcome. The last two treatment options on the bottom of the slide, GOG 169, 179, are very important because they span in time when we became aware of the impact of chemoradiation for primary treatment. Before, when GOG 169 was done, a minority of patients actually had seen chemoradiation as part of their primary treatment strategy, and for 179, it became the majority, and I'll show you that here on this next slide. So you can see that what I just mentioned about the prior chemoradiation therapy, you can see what the impact it was that this had on response rates. So patients that had chemoradiation that were cisplatin-based, when they saw platinum-based combinations in the recurrence, their potential for response actually reduced substantially. And you can see, highlighted in blue, that we were able to show in both of these trials that there was an improvement in PFS, but in 179, we actually had an improvement in overall survival. But if you look at the absolute values, you can see that overall survival was not different from GOG 169, but the control arm underperformed. And it underperformed because of this increasing use of platinum-based chemoradiation as part of their initial treatment strategy. So it's one of those things where, instead of everybody moving forward a step, the line stayed the same, but the control arm actually stepped backwards. So to put this proof to principle, we did a large trial that Dr. Monk here ran, GOG 204, which looked at those two arms. As you can see, they're highlighted at the top and bottom of the curve. And then you can see the two other novel strategies which had phase 2 data to support that they had activity in this disease. Very large trial, 513 patients, 443 that were evaluable. This trial had a number of exploratory and secondary endpoints, which were very important to understanding the impact of treatment on cervix cancer patients. Because remember, if we're not making these patients live very longer, if we make them feel worse, we're not making an advance. So this trial, these are the primary and secondary objectives that were sought. You can see that in there's no significant difference between all of the arms. There's 4 arms here that are being looked at, and in overall survival, again, no difference. But you can see that there's this trend, or at least there's at least support that the paclitaxel-based arm, which was the control arm of this trial, actually seemed to be among the better of the bunch. But again, there was no significant difference. And I think these are important because when you give paclitaxel carboplatin and you're looking for something to do next, these are some other options. Importantly, when they looked at the quality of life during the study, you can see that at least for the standard arm, there wasn't a decrease in quality of life associated with those outcomes. And so the question is, well, where do we go from here? Well, there were 2 kind of things that happened this year that I think helped to support and actually advance our standard of care. One was a trial that was run by our Japanese colleagues that looked at the paclitaxel carboplatin regimen as a substitute for cisplatin. As you remember, almost all of these taxane-based trials that have been done were using the 24-hour infusion of paclitaxel with cisplatin. And so I think a lot of us, because of our experience in multiple other tumor types, have gotten comfortable using paclitaxel carboplatin as a substitute, but we had no data. In fact, we had negative data from an old trial that looked at carboplatin and ipraplatin against each other, which produced lower objective response rates than anticipated against cisplatin. So there was some concern as to whether or not carboplatin and cisplatin were actually identical in this space. So this particular trial, GOG 0505, was a randomized non-inferiority trial of 250 patients looking at the cisplatin and paclitaxel combination. You can see 24-hour infusion with cisplatin on day 2 and carboplatin paclitaxel given in a 3-hour infusion like we do for ovarian cancer. And this trial, which was presented at ASCO and just recently published now, it basically showed that there was no difference between the carboplatin arm or the cisplatin arm, and for either PFS or overall survival. So in both cases in this non-inferiority design, they could not reject the null hypothesis that that either was inferior. Now, it was interesting that in patients that had not received cisplatin as part of their prior exposure, in that group of patients, which was just under half of the women, those patients seemed to do better on the cisplatin arm. This is an interesting observation, but it did pair out in this particular trial. However, if they had seen prior cisplatin, there was no difference between the two. So I think from clinical practice standpoint, since in this country we use almost exclusively platinum-based chemoradiation for most of these patients, this would support the use of that substitution. Now, the other piece of this, and this is what I think we all were comfortable with, is that the carboplatin combination actually was more tolerable. In this particular situation, you can see that the proportion of non-hospitalization was actually substantially higher, and you can see the other differences between the two, including neutropenia and febrile neutropenia. Now, the other advance is very much in line with what we've seen in a lot of the other solid tumors, and that has to do with the novel therapeutic angle in the microenvironment. One of the things that we've learned recently, and I think you all have also helped us with this, is to understand what happens in a squamous tumor, and are using these and leveraging these strategies in multiple different places. One of the very earliest kind of low-hanging fruit for us from cervix cancer has to do with something that we've been doing for a long time, and that's evaluating vascular changes that happen in response to the virus. So many of you know there is a pre-invasive state for cervix cancer called dysplasia. The way we identify it is to look at the cervix directly through a magnifying glass, and with that we look for vascular changes in this dysplastic tissue. And when we find it, we biopsy it, it's graded, and for the non-invasive element of this, there's already vascular aberrations. So we know that there's something about the virus that causes this disease that induces this event for vascularization and its tumor biology. But there are many, many others there, and I just have listed just a few of these that are already under investigation for this kind of a tumor. It's interesting because both HPV E6 and E7 contribute to the angiogenesis process. Through the E6, we see degradation of P53, which increases the proangiogenic factors like thrombosponin 1, which leads to an increase in VEGF. And under E7, with its interaction with RB, retinoblastoma gene, we see an increase in HIF1 alpha. So there's the HIF1 alpha associated RB factor also leads to an increase in VEGF. And so it leads to an opportunity for us to block this by using anti-vascular-based agents. So Dr. Monk here ran a trial for the GOG, a biological trial that was done in a series of different queues, in one queue with a series of different drugs using very specific eligibility criteria that were matched for one trial after another. So this was 227C, which was looking at bevacizumab as a single agent, and you can see the various different characteristics. There's an 11% response rate, but look at the number of cycles of treatment here. So you can see that there are a lot of patients that actually did well on this drug for a long period of time. They were able to get it multiple times over. Here's the PFS and survival curves, and again, similar to what we'd expect in this patient population, these are very short, and you can see at 1 year, the proportion of patients alive is well under 50%. And this is what we're dealing with in this particular disease. It was interesting, though, when you compared that to our experience with our best chemo, it was actually at least as good. And so this line up here at the very top is what is our overall survival curve for bevacizumab alone, and these are all of the other chemotherapy agents that we've studied in the GOG. So again, it's a strong signal that this is a fact. The biology supports it, and of course it was no brainer that we needed to do that next trial with bevacizumab. So this was a study, GOG 240. It was run by a good friend of ours on behalf of the GOG, Krish Tiwari. And it was taking patients with stage 4B, persistent and recurrent disease that was measurable, and importantly with performance status of 0-1. So this is kind of an important feature to keep in mind because performance status 2 patients do not tolerate this drug very well or any drugs very well and leads to a lot of censoring in the study. So it's 452 patients and you can see stratification. The arms of this trial was a bifactorial design, so there was a chemotherapy comparison. One was the paclitaxel carboplatin or cisplatin that we have used over and over and over again. The other was a non-platinum doublet, and actually the point for this was based on what I mentioned before about the decreasing benefit in patients who had previously seen a platinum, and then each of those 2 arms in combination with bevacizumab. So the primary endpoint was overall survival and the tolerability of these 2 regimens. Response and PFS were also part, and there was a number of exploratory endpoints, including quality of life and a number of other factors, exploratory translational factors, which have yet to be reported. This is the demographics that you can see. High number of patients that were performance status of 0. The exposure to platinum was 3/4. So again, very high number of patients with previous platinum-based therapy. The first interim analysis was to assess the platinum versus non-platinum doublet. And you can see here on these curves for progression-free and overall survival that the non-platinum doublet did not seem to perform as well as the platinum doublet. And you can see that in terms of PFS, that was a significant difference. And you can see that in overall survival, the curves are basically overlapping. When you look at the primary endpoint of the study, you can see that there was a substantial improvement of about 4 months in overall survival, moving from 13 to 17 months. Remember, all those trials I showed you before never reached this particular level of benefit. And when we looked at the progression-free survival, there's also an addition of about 2.5 months. When you looked at the individual arms, when you break them down by the platinum and the non-platinum doublet, you can see that those results are here. On the left is the platinum doublet, and on the right is the non-platinum doublet. So even in the paclitaxel cisplatin arm, we saw a major benefit with the addition of the bevacizumab. This is just the subgroup analysis across all the important stratification variables, and you can see they all favor, at least are on the side of the experimental arm. So robust responses, robust outcome. With regard to the toxicity, these are the important toxicities, and I'll just walk you through some of them. Of course, fistula and perforation are a big problem and concern for us. They were uncommon, but they were seen more commonly in the bevacizumab arms. In an analysis that was run by Dr. Monk, they also and presented at the IGCS. They also showed that all the patients who developed fistula actually were ones that had radiation, pelvic radiation as part of their primary treatment. Hypertension, which was known, was seen in a higher level, and there didn't seem to be a tremendous addition to the neutropenia that you'd expect with this compound when it was given in combination. And then the other AEs that you can see here. So in summary, paclitaxel, the platinum-based combination would be considered a standard of care. If bevacizumab added to it does increase overall survival, it's available and is appropriate for the patient, it would be the standard of care to use. In general, more agents do lead to more toxicity, so it's important to look at the issue of quality of life in these patients, and we'll hear more and more about this as time goes on. And certainly, paying attention to what happens to these patients while they're on therapy is quite important to understand to mitigate some of the risk factors such as fistula. There's a lot of new directions going on in cervix cancer. I think the most exciting of which are the immune factors. So all of these agents are under investigation currently. Because of the hypoxic angle and the increase in homologous recombination under hypoxic conditions, PARP inhibitors are also being looked at in this disease. And as you can understand, also the other growth factor pathways are under investigation. We do know from the TCGA there are a lot of targets. So these are starting to emerge, and the trials are now being written to go after these specific elements. So this is just the sequential improvement in survivorship for this disease. It has increased substantially over time, and you can see just as a result of this sequential work that we've made a lot of progress. And so as you know, bevacizumab now is approved in this setting. Now switching gears to the more common disease, endometrial cancer. You can see this is a disease that's quite prevalent. Every year these numbers increase. A lot of it is because we have a very obese population. And it's an epidemic across this country and has continued to increase every year that the statistics have been evaluated. There are a lot of topics in endometrial cancer that need to be sorted out. I'm not going to talk about these all because I only have 5 minutes, but I do want to talk a little bit about developmental therapeutics because I do think there's some interesting new observations being seen here. So the chemotherapy angle for endometrial cancer has continued to expand. We're using a lot more of it as adjuvant therapy, but it comes from our experience in the recurrent setting. So that you can see these classes of drugs have all been able to show both single agent and combination activity in this group of patients. The GOG, similar to cervix cancer, spent a lot of time methodically going through these agents and have essentially identified 3 active compounds: platinum, Taxol, or paclitaxel, the taxanes, and anthracycline adriamycin, or doxorubicin. And these are just the randomized trials that have been marched through over time to identify these different regimens. Quickly in summary, what I can tell you is that as we marched through these drugs, we found out that combinations were more active, but they were more toxic. And ultimately, we were left with a very active but relatively problematic agent triplet to give, and that was TAP, or paclitaxel, adriamycin, and cisplatin. That was the control arm for GOG 209, which looked at this combination versus our more acceptable, I would say, community standard, which was paclitaxel carboplatin, which was easier to give. And I'll draw your attention to that the paclitaxel is a 24-hour infusion with platinum, and it has to be given with bone marrow support, with GCSF support. So this was a trial that was quite large. It was a non-inferiority trial, now over 1,300 patients. And you can see that what we had seen in lots of other studies, that the carboplatin-based arm was actually friendlier and was easier to give, had lower side effects, and it didn't decrease outcomes. So we had the same PFS and OS in this non-inferiority trial, making it a very good substitute for the TAP regimen. So where we're going from here is we're trying to figure out a way to integrate this into radiation for patients that are at risk, and GOG 258 is looking at patients at high risk for localized recurrence, where they're giving radiation, cisplatin-based, followed by adjuvant chemotherapy, or just straight chemotherapy. And this comes up frequently in terms of management questions of what do you do with these types of patients. Now, we've looked at a lot of drugs over the last 30 years. Most of them have not been all that promising. You can see the arms with a very low bar, 10%. Most of the drugs that have cleared the angle are already being used in front line. So we don't have a lot of great second-line agents. And that's really led to an explosion to understanding the biology of this disease. And so what we've come to find out with the TCGA project in endometrial cancer is that there are a lot of genomic and actionable targets. So fortunately, because of all the work that's being done in multiple other tumor types, we have the opportunity to explore a lot of different drugs in this disease because they are aberrant in a high frequency of times. In fact, if you, and I'll show you some data on this, is that about 3/4 of the patients have aberrations in the PI3 kinase or MAP kinase pathway, of which we already have drugs. So it's very nice. In the GOG, what we've been doing is we've been systematically going through single-agent biologics and starting to do double-agent biologics with an attempt to identify promising agents to bring forward in this particular setting. And we've used both response rate and non-progression as that bar through which, or the lens through which we're seeing this activity. And you can see that the angiogenesis agents and the FGFR inhibitors are already starting to move into this space. Fortunately, the PI3 kinase pathway, of which we have many, many drugs, are already in our coming into the angle. And this is that pie chart of the actionable mutations that are seen in endometrial cancer involving the PI3 kinase pathway or the MAP kinase pathway. So let me just briefly walk you through some of the trials that are out there. The mTOR inhibitors were the first to enter on the scene. The first drug was temsirolimus. This is an intravenous mTOR inhibitor, a TORC1 inhibitor. This was given in a group of patients who had not seen any chemotherapy. So these are chemo-naive patients, which is uncommon for us these days. But you can see that there was a response rate of around 25%, and it was irrespective of the tumor type, serous and non-serous, and of grade. And you can see what those response rates were. Retiformalimus, another mTOR inhibitor, was also looked at in a randomized trial versus chemo or hormones. It was physician choice. This particular study, which has not yet been published, but the phase 2 is, and that's why I have both of those references there, basically you can see was a mTOR versus hormone study. It did see an improvement in PFS between the two arms of the study. So the mTOR inhibitor seems to be at least as active or better than basically hormonal therapy. But you know, one of the concerns that's arisen around the use of TORC1 inhibitors is that they actually have a feedback mechanism to activate AKT. And so we were concerned that actually that we weren't realizing the actual full effect of a TORC inhibitor because of this activation. And so right now there's a lot of work being done with AKT inhibitors to try to eke out a better response rate. But we were interested in knowing that the estrogen, the endocrine pathway, was also activated. And similar to what we saw in the Bolero trial for breast, we see that the combination of an anti-estrogen plus a TORC1 inhibitor actually is quite active. We did this trial, just recently published, in 35 patients with measurable disease, both endometrioid and serous, getting everolimus and letrozole. We found the very same class effects you see with an mTOR inhibitor with fatigue, stomatitis, and 3 cases of pneumonitis, but hyperglycemia, which was actually fortuitous for us because a lot of those patients went on metformin, which was an important advance actually that's guiding our next trial. But we saw actually kind of an unusual outcome. First of all, we did see some responses, 31%. That's nothing to be shy about because chemotherapy is actually much worse in the setting. But the responses that we saw were overwhelmingly these CRs. And we were left with these patients trying to say, okay, what do? We have to stop therapy or do we keep going on therapy? So for most of the time, after we confirmed the CR, we stopped treatment, which I regretted because about 6 of those CRs have recurred. But we have one patient out now 5 years from the completion of this trial who has never recurred despite failing chemo. So this was quite an unusual observation, and of course now we're running 2 trials, one to compare this versus hormonal therapy and another to look at it with a triplet of metformin. The GOG is also looking at using an mTOR inhibitor, temsirolimus, in combination with chemo. This trial should report, very, very soon. It's been closed for quite a while, 330 patients, randomized phase 2. 286B is a phase 2/3 trial that's looking at metformin added to paclitaxel carboplatin. This is a placebo-controlled trial that's actually accruing right now at a very rapid rate. And I think that what we've come to learn is that because of these targetable aberrations in endometrial cancer is that it's opening up the field. So we are actively looking at PARP inhibitors in this space in combination with AKT and TORC1/2 inhibitors. There are a number of trials that are ongoing. You can look at clinicaltrials.gov and see this. And I'll just close with these this TCGA. Once we started looking deeper and deeper into the space, we started to find that there was just a ton of opportunities for us. And so it's not inconceivable that we'll actually replace how we approach endometrial cancer based on those biopsies that we take at the time of surgery or at the time of recurrence and be completely, maybe even devoid of chemotherapy. So I think that in this space, for both cervix and endometrial cancer, there are a lot of new things coming. We've been fortunate this year that we have some new approvals, and I think that we're situated now to actually move this space quite rapidly based on a more focused set of studies that are looking at specific aberrations in specific types of patients. And I hope you got that sense from both of Brad's and my discussion today. So thank you very much, and thank you.